I'm going to give it another minute, Diana, just in case a few other people come on, but I'll be ready to start in a moment. Hi, Dr. Sawyer. So glad you could make it.
Hey, Danita. Thank you for the invitation so much.
And please feel free to make comments in the chat or just unmute yourself and make a comment.
Thank you. And I almost chose that background a minute ago.
Gonna give it one more at 6:32. I'm gonna start. Okay. Good evening. I am Danita Terry, Vice President of Programs for the Maryland Women's Heritage Center's Board of Directors. Thank you to each one of you for joining, and a special thank you to our two speakers that we have joined us this evening as well. Before we get started on the topic of women's health equity, I would like to talk a little bit about the Maryland Women Heritage Center. The Maryland Women Heritage Center is the only organization in the state of Maryland and one of the few in the country completely devoted to telling and preserving women's stories. We do this through exhibitions and a variety of programming. As an organization, we are concerned about issues that affect women. Today, we will be exploring and discussing women's health disparities and the impact they have on women of color. To begin the conversation, I want to share some findings and research that was presented by Chin, Martin, and Richmond in their paper entitled Health Equity Among Black Women in the United States. In this paper, the authors say that while Black women in the United States have experienced substantial improvements in health during the last century, health disparities do persist. These health disparities are in large part a reflection of the inequalities experienced by Black women on a host of social and economic measures. Black women have shorter life expectancies and higher rates of maternal mortality. Moreover, Black women are disproportionately burdened by chronic conditions such as anemia, cardiovascular disease, and obesity. These health outcomes do not occur independent of the social conditions in which they exist. Further, the authors believe that no discussion of health equity among Black women is complete unless it considers the impacts of institutional and individual level forms of racism and discrimination against Black people. Nor is a review of health equity among Black women complete without an understanding of the intersectionality of gender and race and the historical contexts that have accumulated to influence Black women's health in the United States. The history of Black women's access to healthcare and treatment by the U.S. medical establishment, particularly in gynecology, contributes to the present day health disadvantages of Black women. The development of gynecology as a medical specialty in the 1850s ushered in a particularly dark period for the health of Black women. With no regulations for the protection of human subjects in research, Black women were subjected to unethical experimentation without consent. Consider the stories of Henrietta Lacks and Fannie Lou Hamer, to name a few. And the authors add, Even in more contemporary times, these abuses continue. The health of Black women is measured in their disproportionately poor health outcomes, but it is a result of a complex milieu of barriers to quality health care, racism, and stress associated with the distinct social experiences of Black womanhood in U.S. society. So now we have the context, and I am eager to begin the discussion, which will be led by Dr. Donna Hubbard McCree and Dr. Tekisha Dwan Everette. I would like to take a moment to introduce both of our speakers. Dr. Tekisha Dwan Everette is the executive vice president for the Trust for America's Health. And I'm sorry, Tekisha, if I just messed that up because I think I missed a letter, a word when I was pasting your your bio in here. She works in partnership with TFAH's president and CEO to chart and implement the organization's strategic direction and priorities in order to improve public health and promote equity. A successful executive leader and public policy strategist with a passion for health justice, Dr. Everett's career includes service in the nonprofit, state, and private sectors. Most recently, she served as the inaugural executive director of Health Equity Solutions, a statewide nonprofit dedicated to advancing health equity through policy and advocacy in Connecticut. She also served as the managing director of federal government affairs with the American Diabetes Association. She is an alumna of the National Urban Fellow America Leaders of Change program and a member of the Association of Black Sociologists. I'm going to take a little break there because I've been reading a lot so that I'm not stumbling over my words again. Dr. Donna Hubbard McCree retired from the Centers for Disease Control and Prevention after a 42-year career in public health and pharmacy. In 2024, she launched NXLS4Health LLC. Dr. McCree has worked. I'm sorry. Dr. McCree's work has varied from mentoring postdoctoral fellows to leading projects focused on measuring disparities in HIV and STIs in the United States, and has resulted in the development of effective HIV prevention strategies for women and men who experience high risk for infection. Donna, would you like to add anything to your bio? So I'm sorry, I'm just going to say this. Because of the sort of uh, atmosphere going on with health agencies and other federal agencies, I'm not comfortable with reading her full bio. So if you want to add to that, feel free. I'm sorry if I botched it a little, but Donna has been a has been honored in many ways for her great work at the CDC. And I'm going to just let you add if you want to, because I know it's sort of a touchy situation. And the same sort of applies to Tekisha. We're sort of in a weird way right here in our country right now. And I'm trying to protect people's federal government backgrounds and livelihoods when I'm reading their bios today. So, with that said, I'm going to first ask you ladies if there's anything that you wanted to add to the the context piece that I read. Did you have any comments on, you know, women of color and health disparities?
Donna, would you like to go first? Certainly. Good evening, everyone. And I want to just thank Danita for that introduction and also for your carefulness in how you did the bio. It is greatly appreciated. And thank you also for setting the background for the talk that we're going to have tonight. I think that one of the things I always said as I was doing my work was it's important to talk about the context if you talk about the disparities, if you talk about why women experience, let's say, higher cardiovascular issues than men, or if there are, if you talk about maternal mortality and the populations that are affected there, or my expertise is HIV and other STIs, if you talk about that, then don't give the data without the context. So I'm grateful that you talked about the social determinants and how those really are the drivers of the disparities that we see. And if we were to address those disparities, then we would get to a place where we have equity for all. Everyone's health would improve, and I think that is the goal of what we're doing. That's all I'll say about that, and look forward to this conversation tonight, and hope it will be more a discussional kind of environment here. Thank you.
Yeah, I'll add to that to say, one, of course, thank you for the invitation to be here tonight. Thank you for your gracious introduction, and thank you to all who are attending and those who will hear this recording in the future. The additional context that I'll add, and it's not necessarily additional, it's more like I'm kind of adding on, I guess, to what has already been said, is that I too, like Donna mentioned, don't believe in providing the data or the information without setting the context. In particular, I'm a good storyteller, at least I think I am, and I love a good story. I'm not going to lead there on this point, but I'll say one of the things that I believe is true is in talking about that context is you can talk about um, disparities in a conversation and just kind of lay those out there and say like these are the numbers, quote unquote, this is the data in that way. When you then link it to a broader context and talk about the social determinants of health, that links to the kind of the story of kind of why we see those things, but even underlying that is the question of how did those social determinants come to be? And so I am I'm a macro sociologist. I believe in thinking about systems and how systems operate and how they function, and social determinants of health. Sometimes we talk about that disconnectedly as if it just somehow we woke up and they were there. And the reality is they're the result of policy decisions and choices that have been made over time that have created those social determinants. And we have to link discrimination to the reason why we make those policy decisions. Discrimination upon race, discrimination upon gender, discrimination upon geography. They all kind of pull together as to how we get to those policy choices that then link us to the social determinants of health that then link us to those disparities. And so I just wanted to add that in a little bit of a flavor to a color to that context and broaden that out just a little bit more.
Thank you both. So, with that, I'm going to pose my first question. And it is, what are some issues women face when seeking affordable and accessible health care? Either one can go first.
I'll yield
Thank you,
to
Donna.
I'll yield to Tekisha since I started the last time first.
Oh, then I should have had you. We should have done it differently. No, so some of the disparities that women face when seeking healthcare. So I'm going to take a step back and just do a little bit of a history 101 for us about what we already know in general. When we think about our healthcare system and how it's been designed in its early stages and how it worked, it was very much a space for those who had wealth and privilege to really access the best of our healthcare system. So if we go all the way back into the origins of healthcare in the United States, doctors went into homes and people were very much available on call. And when you think about who could access that, it was those who had wealth and had access. Over time, we've created what I would call a secondary and parallel system to that, where we were like, well, wait a minute, we need a working labor force. So we need to be able to make sure they have access to healthcare as well. And so we created clinics and we created free hospitals and things of that nature that were slightly substandard in how we resourced them, not necessarily the people who worked in them, but how we resourced them to bring care. So if we have that kind of as our kind of quick 100 years of understanding or 200 years of understanding of our healthcare system, it stands to reason that if we then think about, well, what was happening to women at that time and other minoritized populations? Women were not in the workforce. They weren't in the labor force. They were home givers and home and caretakers in a lot of ways. They might have been farmers and assistants to their spouses, but they weren't in the kind of routine wealth, right? So you're then by proxy only able to get the best health care that your husband or your spouse can afford, or you're kind of on the poverty side of things and you're in that secondary space of health and wealth. Also, in many ways, as our context evolves, women are not independent, mindful makers of their own life and their own health, right? Their existence is very much tied either to the spouse or to labor if they are working. And so when you fast forward, we just generally have a system that wasn't built and designed to really care for the needs of women and how they enter into and need health care. And you see that in the ways that we have late gynecological care, that we don't have all of these things that are readily accessible, that even gynecological care is considered specialty rather than primary, when arguably for many women from puberty on, it is your primary source of health care, though there's a lot of other things that we do need to and probably will talk about tonight is important for women to be mindful of. So the barriers are you're walking into a system, and particularly Black women who were, again, considered laborers and care for this. So you're walking into a system that really isn't designed to care for your needs daily and is built on the system of wealth and male dominance in terms of who it's intended to work for. So when we get into our time today, we still face some challenges in our healthcare system where women are paternalistically treated in healthcare, not necessarily the deciders of their own healthcare, or seen, if you will, as the deciders of their own health and healthcare options. Issues of thinking about how we really only consider women and their health as their ability to procreate and reproduce rather than the whole story about what women are. You see all of these things in how we then actually treat women and the way we think about women in the context of their treatment. That underlying then comes through how are we actually thinking through the education of how we need to talk to women differently, engage women differently, and really help them gain that quality healthcare that they actually need. And what's interesting in all of this, like all of the stuff that's in the backdrop, because that's the like, let me give you kind of a history there. But all the stuff in the backdrop is what we know, is that from the beginning, women have been the backbone of families, the backbone of decision making, are very clear about systems, are very clear about how things work, and then also but also then are faced with not getting all of the resources that are necessary, seeing unequal treatment and in the context of the execution of their healthcare. And the last thing that I'll say about this is if I'm saying all of that broadly about women, it becomes exponentially more difficult for women who are minoritized. And that means women of color, that means women who are in geographically rural areas, that means women who, like all of the kind of different ways that women show up at the intersections of their identities. I'm going to pause there because I've said a ton, and I just want to make sure Donna has space in this conversation. So Donna, I'll bring it over to you.
Okay, thank you. And thank you for providing that background. I think you did an excellent job of sort of giving the history behind where we are with the barriers that women face. And that question has the word affordable in it, but I would say that that's a problem. You talked a little bit about the insurance issues, the lack of access to quality healthcare insurance that's available. I think that's an issue. You talked about women also being caregivers. Sometimes women, particularly the traditionally marginalized communities, may be heads of their household, and transportation could be an issue. How do I get to it? There are also issues around the availability even. Let's say for women who live in rural areas, what kinds of services are available there for them? The same quality, or how far will those women need to travel to get to a physician? And then what types? I know the word diversify might be not a word that we're talking about here a lot in the times in which we live. But if we have a workforce that's diverse, it may meet the needs of women better. And that when I say diverse, I mean not just physicians, but all types of providers, physicians, assistants, nurses, pharmacists, social workers, everything that's going to sort of treat women holistically. Mental health services are issues as well, and being able for women to have access to those. The mistrust that still exists. You mentioned Henrietta Lacks, and also, and I've heard this study not characterized correctly. It should never be called the Tuskegee syphilis study. It is the study of syphilis, untreated syphilis in men in Tuskegee. And that sort of creates sort of a mistrust in the medical system, and that might be a barrier. Communication issues, being able to talk to your providers and sort of share the needs that you really have, and then having people respond back to you in a manner that shows you they're listening to you, they hear you, you know, and they're understanding, they're trying to really care for you. And I think all of those things are important and things that we have to consider. And really, when you talk about affordability, that piece I think is major, and has to be at the forefront of the conversation. Another thing we don't really talk a lot about is education, which is one of the most modifiable social determinants of health, and how that plays into your ability to even be able to ask for what you need or to understand what's coming back to you. So I think those are some of the barriers that women face. And sometimes too, there are data that shows that women may not get the same treatment from physicians when they have the same types of pain or the same types of problems. Some symptoms of some diseases might look different in our conditions in women than they do in men. And if most of the work has been done in men, that symptom may be missed. And so all of that together, I think, all of those items together kind of create the barriers that we see for women in our country today. I'll leave it there.
Wow, I think that was an pretty covered a lot of the reasons why we are not getting the care that we need. I know me personally, I pretty much stopped seeing male doctors because the first time a doctor told me, no, you can't be feeling that on a part that he did not have that I had, I said, no. And then over time, just misinformation or not giving me all of the information about medications and their reactions or what could negatively react to certain medications. I think it just all falls into the categories that you all have identified as to why women are not always getting the care that they need and I would say deserve. So, how can women affect healthcare policy decisions at the state and national level?
Wow.
I'll answer that. I'm going to go back for a second and say something related to what you just mentioned, Danita, and Donna said something around this about diverse, making sure you have diverse healthcare options. And so there's a lot of work that has been done, a ton of research about the importance of concordant care. A lot of time people talk about concordant care just along the lines of race and ethnicity, but there's also a lot of work that talks about gender and what that looks like in terms of concordant care. And so what that means is people are generally more comfortable. This is just like generally. People are generally more comfortable in sharing intimate details with people that they have shared experiences with. That could mean shared racial, shared ethnic, shared gender. And so you find that people are much more comfortable when there's some level of similarity with the person across from them, and particularly when it comes to sharing intimate details. And health is intimate, whether it's your fear about whatever your health situation is, whether you're sharing something that is sensitive with your healthcare provider, such as your risk for HIV or an STI, any of that is really it's intimate, and you want to be able to ensure fidelity and trust. And that almost always links into, does this person
That-
live near me? Are they in my community? Do they look like me? Do they know people like me? And that's along all the lines, right? So I think that's just really important. Like when you say your story of saying, I don't even go to male doctors anymore because I'm much more interested, and you didn't say this, right? But you're much more interested in that level of empathy and connection that you get with somebody who you think, again, shares some shared experience with you. That leads to, I came to that because that leads to me actually answering your question. When you say, what can women do to impact healthcare policy? I think there are a number of things, but the main thing is to tell your story. I'm a huge fan of policy change happens because people are invested in the stories of the people who are coming before them to ask for the change. We have tons of people who can do all of the data. There's like so much data out there. I teach and I tell my students all the time, I don't need another researcher. Like I just don't. A lot of the problems we have seen in the world, we've already researched almost every answer that's out there. Love research. Part of me is a researcher, but I'm just saying we have to be able to convert that data, those numbers and all of that into real stories. If you just pause for a second and stop thinking about healthcare and sit back and think about what motivates you. What's your favorite song? What's your favorite movie or television show? You're invested in the story in those things. You like how the story was themed together by the artists who made that music. You like the show because the show has a great storyline. And policymakers are ultimately motivated by the stories that are told about their constituents, about what they're hearing. And all too often, what we're facing is there aren't enough diverse voices, and especially women in the conversation telling their story, how what is happening impacts them when it comes to healthcare. So that's my number one, tell your story. My number two is get involved. Right? We don't have to create new opportunities or new groups. There are a ton of people out there who are a ton of organizations out there who are engaging in sharing stories and providing data and doing all of that information in ways that are comfortable. I think it's no secret in my bio. I've been a federal lobbyist before. I'm not anymore, but I've been a federal lobbyist for a number of years. And so policy and advocacy is the way I really engage and think about things. So I say, when I say get involved, you don't have to be a lobbyist. It might not be the thing that interests you. You might not be the person who's like, every day of my life, I'm going to make this policy change. Find where you fit in the context of change and do that well and get engaged. But Donna, I'm sure you have something you want to add to that.
Yeah, I think you're correct in what you say. And I always talk about education, engagement, participation. At first, you've got to learn about the issues and why they exist and what can be done to address them. So let's say, for example, you live in a rural area. It takes you 2 hours to get to the closest physician. The hospital in your area only provides certain services. They're limited in what they provide. There's no transportation for you to get from, let's say you don't own a car, there's no transportation for you to get to the closest provider. So what can be done about that? There might be some policy decisions about providing a transportation, or maybe making changes to the hospital system in your area, or bringing in new providers, or having federally qualified health centers in your area, or something. But you need to know about it. You've got to be educated about it. That's where forums like these and others that will invite communities in to tell them, this is what's going on in your area and this needs to be addressed. Why do we have maternal mortality high rates in your area? Well, it's because of this. And what can we do about it? That's all educating and then getting engaged. And I know it's kind of, voting is important. I don't know what's going to be going on from here forward, but I'm going to say that's important. I mean, you really do. You need to be registered to vote, and you need to get out there and vote and make sure that how you're voting is going to impact the needs that you have in the communities that you serve. I think that's going to be important as well. And then there are so many different grassroots organizations, community-based organizations, faith-based organizations, civic and service organizations that can affect policy. And we're going to need those types of organizations, especially where we are now. We really do. To get out, to get up, get out there, talk to, and a lot of policy happens at the state and local level. You know that, right? You can really affect change in your community there. So it's going to be important for those groups to go out and to educate and to mobilize communities, take actions that we know will get the attention of the people who do make those policies. And then advocate for what you need, I mean, strongly. But I do think it all begins with educating and understanding what's going on. So let's continue to have these types of discussions and expand them, and expand the people who are speaking. Even like the storytelling is so important. Having folk come in, and I'll just share a personal story. That my intern is retired. I've been seeing her for 20 years, and a woman, and I prefer also the same sort of female physician. She directed me to her partner and another female physician, but I didn't quite know her as well. I did go in to see her, and Danita knows that I'm very health conscious. You know, when she walked in the room, she didn't have her mask on. And most of the time, the physicians will ask you, would you like for me to wear a mask? Some of them do, you know, they'll ask you that. And I asked her if she wouldn't mind wearing a mask. Oh, that became an insult. And from that point on, she let me know how insulted she was by that, in terms of how the language she used towards me. She chastised me for complaining about a health issue, saying, you know, people, she talked about my socioeconomic status, and people who were not there didn't have the same things. And then she went on to describe how small my legs were, small, but they were muscular. I mean, it was a let me treat you poorly because you actually challenged me on speaking about your health and wanting something that I wasn't willing to do. Well, what action did I take? I found someone else. And it took me 6 months to get an appointment with that person, but it was important for me not to go back and be treated in that manner, because clearly my best interests were not in hand. And you know, I think I had the option to do that. There are people who don't. And they either don't go at all, or they continue to go and are treated in a manner like that. And the physician, I just saw her Monday. And when I finished my conversation with her, I told her, I said, thank you. I appreciate. And she said to me, well, we're here to listen to your needs and show you that we care. That's our job. So you're thanking me for doing my job. And I was like, yeah, but I know people who have your position that don't do their job. So I am here because I can do this. And it made me, I was happy to be there and to have that experience, but I was so sad to think of, I mean, I'm from humble beginnings, and think of people who can't do that, who don't feel empowered to do that. And those individuals are, you know, the outcome is poor health, and it becomes generational. So I think I tell that because, as Tekisha said, it's important for us to tell our stories. That's how we affect change.
Danita, if I can add a comment that's in the chat box.
Yes.
Kaylin said that she made a point years ago to have mostly women doctors. I feel like I can discuss things better with women doctors, and they're better listeners. Thank you, Kaylin. Hi, Gina.
Thanks.
Gina, can you mute your phone, please? And else, would you like to say something?
I think Gina just went on mute. I thank you, Juan, for sharing that story so much, because I think it's super important. And the reason I'm coming off mute before Danita asks the next question is when we're talking about what we can do, it's to always remember our power. And so often, for a variety of reasons, women particularly forget their power. And particularly when it comes into healthcare, health policy, public health, all of those things. It's just to remember your power. And I tell doctors all the time, particularly when when it's the first conversation and I'm changing a doctor, that I'm interviewing you, right? So I don't go in for my first visit as a clinical visit. It is legitimately, what's your bedside manner? Kind of like, let me get to know you because I have a lot of health knowledge. And so I am an active patient in my healthcare. And so it's important to me not to engage with a physician who thinks they're God and has like the one answer to everything, but who is in conversation with me about my options and my choices, because I most likely always have an opinion. And so I need to be heard in that opinion and to be kind of saying, that's an option, and here are some others. So it's important that we recall at the point of our own healthcare that we have a say. It might be limited and we might have to wait 6 months to get to the next person, but we have a say in who is helping us and who's providing our healthcare, or said differently, who's taking us on our wellness journey. And I think it's really important to make sure they're not a sick care doctor, but they're literally invested in your goals around your healthcare.
Well stated. And in fact, I am looking for a doctor for that very reason. Um, I went to see the doctor for one thing, and she's a specialty doctor, but she wanted to concentrate on something that my doctor of over 30 years has been handling. So I kind of said, okay, I guess I appreciate her interest and her concern the first time I saw her. But when I went back again and that was still what she was focusing on instead of her specialty area, that was it. I'm now looking for another doctor because you didn't hear me when I told you the first time that I've been seeing this doctor for 30 years. She's taken very good care of me. I have had no complications as a result of her care. So I'm letting her handle that. I need you to handle this. So I,
You just dropped on mute, Danita.
I just wanted to take a minute to see if anybody else had anything they wanted to share before we move. Hi,
Yeah.
Kate. Thank you so much for being here. Please go ahead.
Kate, you're muted.
Well, I was just putting in the comments. I'm a slow typer. Dr. Everett, I really relate to your comments about a lot of doctors, particularly males, have this God complex. I come from a medical family. My father was a surgeon, but he really treated people where they were and was one of these small town doctors that got paid in chickens and produce and everything else. But I've had over the years, almost to the extent of abuse, uh, my complaints have been ignored by male doctors, and almost to the point of abuse. And yes, I found female doctors, for the most part, much more open to what's going on, but not all. Um, I've and I think when we're trying to make changes in our systems, I have seen, as a privileged woman going into hospitals, I've been waiting in the waiting room 4 to 5 hours. Maryland has the worst emergency room waiting times in the entire country. We're 50th. We're 50th. And I have seen and observed conduct in emergency rooms that is just deplorable. And I have gone. I'm working with different organizations to go in front of Maryland legislatures to testify about the needs of everything needs to be improved in our system. And I've worked on certain issues, but I've viewed firsthand the discrimination, and it just makes me furious about what I have seen. And you're right, we need to advocate women need to own their power, and they need to advocate, and stories are the best way to make an impact. Talk to your local legislators, and volunteer to tell your story, because that's where the difference is made in getting attention. So anyway, I just wanted to re-emphasize, you guys are right on about your stories are valuable and powerful, and women need to own their power and not be ignored. I mean, I almost died because I have people of endometriosis, because male doctors were saying, oh, it's in your head. And finally a female doctor came along and basically saved my life with emergency surgery. So that's only one of my stories, but the whole point is we are going in and interviewing your doctor. That's what I've been doing, wondering if I'm trying right now, trying to understand whether it's worth paying a doctor who I'm questioning right now as being like a concierge doctor. I'm thinking, I'm not getting my money's worth there. And that is a luxury, but I don't have tons of money, and I'm thinking, I think there are other doctors out there that could help me more. So, and this is a female doctor. So whatever it is, we need to speak up what our personal needs are, and not only for ourselves, but looking around to see what is unfair, what are unfair practices. And our stories can make a difference in our state legislatures.
Well, Kaylin has a story today too. Earlier we were talking about urgent care. So unfortunately, Kaylin was in urgent care today. After x-rays, she found that you have arthritis in your knee. I'm sorry, I feel your pain.
Yeah.
The woman doctor really, really she really took the time to answer her questions and not rush me out the door. That means a lot, especially at urgent care. Thanks,
Right.
Kaylin, for telling that story.
Mm-hmm.
And I'll just add to Kate's comment, if possible, too, not all women feel empowered to speak, or some cannot. I mean,
Intimidated.
for various reasons. That's why we have to be the voices for women who cannot, and make sure that they are not forgotten and that their stories are told, even if we have to be their storytellers. I do think that we have to advocate for those who aren't able, for whatever reason, to advocate for themselves.
So a few of you all have mentioned some groups that either you are attached to, involved with, and I'm wondering if you all could share some of those groups in the chat so that we can all be enlightened and perhaps um, participate in some of the things that these groups are doing, or at least consider how we can add to the stories that are being told. So if you don't mind doing that, I would greatly appreciate it.
While you're adding to the chat box, Susan had a question. How do we ask to interview a new doctor, especially if one has little or no insurance and can't afford to wait or pay for another visit? Good question.
Yeah, I think that's an excellent question, there are a few things that have to be acknowledged in the answer to that. One, when the privilege and the option to interview a doctor is one of a privileged position, but even for someone who is uninsured or underinsured, if you're going to a free clinic or a federally qualified healthcare clinic, like a federally qualified healthcare center, there are multiple doctors who work there. So you can go in and have an interaction and like in the visit and just either say, is there someone else who can see me right now? I have a few more minutes, I can wait. Or finish that visit, unfortunately, and then quietly ask the front desk person or somebody else, when is there another doctor here? Because you might have to return. So it might not even be like an interview directly at the moment, but it's really just remembering consciously, even when you're uninsured and underinsured, you have an option on who you're paying to take care of you. And that might mean something different for you, coming to the doctor at a different time at that center or going to a different center. those are kind of options. And I'll just say as somebody, I'll give you an example of this because I've been uninsured before. I've left the doctor's office because I'm paying for that. And literally I have ended it and have been clear. I know how you bill, and I'm the biller in this particular situation, and I'm no longer going to have this visit. So here's a portion of what I owe you for the portion of time we spent together, and I'm gone. And of course, didn't sit so well. And no, you have to pay the full amount. No, I don't. And you can sue me, but this has not been comfortable. I'm leaving. That happened to me when I was uninsured. But as an insured individual, even in the hospital, I've asked for a different ER doctor. And I think that's just the thing sometimes when it comes to healthcare, at the provision of it, we do give a little bit of our power away because we're either sick in the moment. And so we're like, I got to understand what's wrong, or I have this question, but we don't remember at the end of the day. It's kind of just like when you mentioned before about voting, the people, they work for us on some level. And this is something that we are paying for and engaging. And so again, the privilege point, it's when you're not in your ailing, like when you're in like an acute chronic condition or a chronic situation, you might not feel like you have a lot of choice. But when you do have the options, it's just a reminder that we do, and to share with our loved ones that they too have an option.
And I'll say to that too, if I'm assuming that a person has access to the internet, everything, but there are reviews of physicians out there. And I've spent a great deal of time reading through those reviews. Not only on you can actually, let's say the person's in a group practice, you can see reviews. U.S. News and World, is that U.S. News and World Report also does reviews. There are healthcare groups that do reviews, and you can kind of see, and you can go back as far as like 5 years for some of them, to see if there's been some kind of improvement or not. You know, if you had something 5 years ago and then you see within a year, the same thing, then you know it's a kind of a continuing process and you may not want to be involved with that. And then word of mouth too, talking to people who have seen that physician is quite helpful. And people that you may know who are physicians. I've asked that question of people: where do you go? Do you like your physician? You know, what are some of the qualities there? And I heard someone, Kate, I think, talked about the concierge practice thing. My husband's in a concierge practice. He loves it. But that's him. But I found the physician I just mentioned that took me 6 months to see, because he asked his doctor, said, well, she needs a new internist. Can you recommend somebody? And that's how we were able to find her. And he sent the reviews and everything right along with it. So I think you can do some research. And for women who don't have that option, again, I always think about that, then there have to be organizations and conversations and groups that will do that work for them and get out and help them, patient navigators, peer, groups that help those women. We're going to need to put more energy and time into those types of services, especially now. That's going to be important.
Yeah, as you were talking about places for healthcare service for uninsured individuals in clinics, and what do you all feel like the future, or at least sort of like the 4-year future of those institutions? Do you have an idea, or do you feel like a lot of them will be shut down? Do you think healthcare will be minimized by what's going on in the federal government now? And if you can't answer that question, I understand. But it just came to me as when Tekisha was talking. So does anybody want to touch that?
No,
I think I missed the question, but go ahead, Donna.
I was gonna say I'm retired. But Tekisha is not. So I think I probably have just a little bit more, just a little more latitude. Not a lot though, just a little. And I'll say I'm concerned about how affordable healthcare will be affected. I don't know about expansion of services. Let's say like Medicaid expansion. I'm concerned about that. I'm not sure about the availability of services for people who may be in whatever types of minoritized communities there are, however that is socially constructed. I don't know if there will be people going into healthcare because they are concerned. And I'm very concerned about the dearth of information that's going to occur because the people who are doing that kind of work are being removed from certain areas. But I do think that it's going to be important to still educate, engage, and participate, probably more than ever. It's just how you do it. And I think that's going to be the key. We've been here before, well, maybe not exactly here, but we've been in some environments that are challenging. We're going to have to draw on what we've learned and put that to use now and be very careful about how we do it. That's my thought.
I appreciate you sharing that. And I think it's something that we all needed to hear and just prepare ourselves for so that we know what actions perhaps to take before that actually happens. Kate, your hand is up. You're muted. You're muted.
Thought I took care of that. I put in the chat box Anna Palmisano's name and her contact, her email. I worked with her on working on the Maryland Patients Bill of Rights. That should be everywhere I go into a doctor's office or into a hospital. I ask them, where are your patient's Bill of Rights? I was actually in the hospital the other day. So I, asked them and they handed me the little brochure but it should be pasted up on every wall in the emergency rooms and in the rooms that you're waiting in and so on. So whenever you go to if you ever go to a hospital, ask them where's your posting of the Maryland Patients Bill of Rights. It's important to hold them accountable because they are supposed to have that on display and have for handouts. And every person that goes through the emergency room or is admitted to a hospital. Also, she's working right now on getting proper staffing levels in hospitals. That's why we're having so many long waits, is because they don't have enough staff that is working in the emergency rooms and at the hospitals. But so if anybody's interested in that, they certainly can talk to Anna, and she'll have maybe other instances where they're working on specific equity bills that are going. But anyway, it's something. It's a contact, and it's using our voices and collective voices too, to getting your groups that support, like your sororities and your neighborhoods and so on, to collectively give testimony or write testimony into your elected officials. I mean, if we don't speak up, no one's going to listen. So
It's true.
Jerry's, would you like to unmute your phone and add your information you put in the chat box, or you can just do it the chat box way?
I could do it both ways.
That'd be great.
Well, hi everybody, and thank you for this. I am frankly here in showing up in solidarity with my new friend Danita, and we recently started rolling out allyship gatherings, which I'd frankly like to invite all of you to join us on March 8th, and we are looking at unveiling commonalities. And I also see this as an opportunity. I know this is going to grow beyond simply unveiling commonalities. We're going to be, it's going to be, I started to brainstorm as I was listening to this conversation about pooling resources, and who knows, maybe we can start bending the ears of philanthropists, maybe female philanthropists who are also billionaires out there, and maybe we start something new with healthcare. So anyway, these are some ideas that are going on in my head. And so I did put in the chat, a little about 2 years ago, I read the book White Women: What You Already Know About Your Racism and How to Do Better. And it really struck a chord in me. And that was why I founded the White Women Showing Up community. Because Sayira Rao and Regina Jackson, the authors of Brown and Black Woman, said, white women, start with yourselves.
Mm-hmm.
Start with yourselves. Don't put the burden on us, and start unpacking your white privilege on your own. And so that's what this space is about. It's a safe space for white women, for us to explore, say the uncomfortable things amongst each other, and find our way to articulating in a responsible way. And I was sharing about that in a networking meeting in October when I met Danita, and she was like, "Hey, we need to talk." And that was how our Unveiling Commonalities allyship gatherings began. So I'm doing a lot of listening here, and but also some ideas are popping, and we're in critical times, and critical times are times of immense transformation. So I think at the same time there is reason to be super concerned and reason to get super active and come together and be creative and pool resources and keep and we stoke the fire of hope amongst each other. So that's what I have to say.
Mm-hmm.
Thank you, Jerice, and thank you for mentioning the allyship meeting on March 8th. And I would invite and encourage anyone who's interested in building allyship among women to join us. And it's funny that it was also mentioned here about the power of the voice and working together and collaborating. And so when Jerice and I met and we started talking, I was thinking that, oh my God, we better brace ourselves. And women have got to start being very connected to each other so that we can be a formidable block, a formidable power, a formidable show of resistance to things that are detrimental towards us. And there have been many things that have happened in that way in the last 4 to 8 weeks. So I invite you to come, and if you just want to listen, fine. But I'm sure that you'll feel compelled to contribute to the conversation. So thank you very much, Jerice. I have a couple of more questions that I hope we can get to. It's already 7:30. But the whole thing of accountability, which we've talked about a couple of times, would either of you like to talk about how women can hold elected officials accountable for their promises regarding healthcare access and affordability?
So I can start. One thing I think you're going to have to know what your legislators are doing. What are they doing?
Yeah.
What are they voting on? What's their record, and do their votes positively affect your community or you? Do you know that? I think, and then the second part is, and it's hard now to find that kind of information. People are concerned about the validity of some of the information that they see, but the states do report cards. You can find that kind of work. And there, Robert Wood Johnson Foundation, the American Public Health Association, there are associations of legislatures. They all have that information, and you can see your state should have information about the bills and the policies and who voted how and how did they affect your community. So I think part of it is knowing what they're doing. And if you find that they're not doing what you have elected them to do, there are ways to get involved. You see now people going to these town hall meetings and making their voice known at those meetings. That's happening. People are writing, doing letter writing and emails. They're visiting those locations and talking to their congresspersons and to their legislatures and their state and local governments. They're also sort of rallying. You see those types of things happening in communities. I know when I'm in Atlanta, Alpharetta, north of the city, but I've seen a lot of that sort of mobilizing. And it's not necessarily and this is we can't talk about policy, but it's the people you would not have expected that are out advocating now, because now it's affecting everyone. And so I would say making sure you understand how they're voting, what they're voting on, what's available, what bills are they passed, what are they advocating for, and then letting them know your opinions about those things, whether it's through your attendance at meetings or your emails or your letters, and then working with the groups who are actually affecting policy and affecting change and becoming involved in that way. I think that's important to do.
Yeah, and hopefully all of that will actually have an impact. I understand that calls to the Senate and Congress have increased, where they were getting a scant 40 calls maybe per day. It's now over 1,900 a day. So I would say get on the phone as well and call your folks in Washington in addition to your local elected officials.
And some people are using social media. I don't know, I think that's you've got to be savvy with that kind of thing, because that can or cannot, it can be a positive thing, it can be a negative thing. It just depends. But there are people who are also getting engaged in those types of things as well. Group chats, group meetings, organizing in those manners. And it really depends on what you're most comfortable with. And what do you think would be the most effective way to advocate in the area where you are?
Yeah, I'll add on a local and state level. I'll start there and then I'll go kind of federal and national. On a local and state level, local members of councils and state legislators are the most accessible in the list of representatives and policymakers that we're talking about. It is no secret, a lot of folks these days have Facebook pages, Twitter accounts that they themselves, particularly at the local and state level, are operating. And so direct messages asking the question, I don't think we have to call people out. It's a lot of call out culture. And I'm a fan of calling in people. Like, I don't need to really call you out. Let's have a conversation. So direct messages to say, hey, I know this is happening. What's your position on it? Is a really effective tool. It doesn't have to be a long email. It doesn't have to be a long conversation. But as you're going up the kind of ladder of policymakers and you're going to that federal level and you're thinking about congressional members, even at the state level, writing a letter, fun facts, if you're writing a letter to congressional or state offices, someone has to answer it. 100%. Every single letter that is sent to a congressional office is answered. Right. And if that's even in an email, so it might take a little bit of time, but going on the record to make a statement about what you think, even asking a question about what's your position is a wonderful opportunity. Going to town halls, as Donna said, and if town halls don't exist and you're comfortable with it, creating the town hall yourself and inviting the members are really good ways to kind of engage and hold accountable. But fundamentally, you have to think about accountability from the moment of election all the way through. And so we're talking a lot about they're elected and they're in office now, but the reverse of that accountability is showing up when they're running for office and being very clear what your thing is. Because people may not be talking about healthcare. A lot of folks run by polls, right? So it might healthcare or health issues or public health might not be polling high. But if there are folks who are asking, hey, what's your position is really important. And I'm going to give you a non-policy example of this, how easy it is. Tonight, it just happened today. Who knew this story was going to come up? It's a non-policy story, but it's an example of how effective this can be. Today, I got an alumni donation call. Some kid at a university is calling me from one of my alma maters and asking me to donate. And I was trying to quickly get him to the point because we all don't have a lot of time. And I was like, what are you calling for? What do you need? And I was like, hey, I got a meeting coming up. So if you have something you want to ask me now. And he finally asked, right? We're calling around asking people for donations. And my question back was, I was like, thank you so much for the question. Do you know what the university's policy is right now and how they're responding to the Department of Education's directive on DEI? And he was like, no. Now, fun fact, I think it's ridiculous that whoever in these days and times, because he knew he was calling an African American alumni, did not have some talking point prepared for him for this. That's a side note. But he's like, I don't know. And I said, well, I invite you to ask anyone at the university that question and have them or you call me back, because that's contingent on whether I give you money or not. That took me 3 seconds to say, but I made it clear in that conversation what I care about right now, and that's the answer that I need a demand for my dollars. You can do the same thing with your policymakers. Hey, I don't see a record of anybody talking about this right now. There's no bill that's happening in Maryland right now on this. What are you going to do about X, Y, and Z? Period. Because that lets them know, oh, this is something of interest to my constituent. As I mentioned before, I've been a federal lobbyist, I've been a lobbyist at the state level. And I can tell you the number one most important voice is the person who lives in that person's district. No matter how much I know, no matter how much I can come and say, I got 100,000 people who care about it. If Jerice makes that phone call, if Martha makes that phone call to that member who's there, it's going to make a difference and change. So this goes back to that kind of holding accountable, and it doesn't take a lot of time. What's your position? Where do you stand on this? Here's where I stand on it. Call me later.
Thank you. Thank you. So this is my last question for the evening. And I was hoping that you all could help.
Danita, I'm
Jerice has
sorry,
her
Jerice
hand
is
raised.
her hand
Oh,
up.
I'm sorry, Jerice. Yes, ma'am. You're muted right now. Okay.
Yeah, I was trying to get it to unmute. Thank you. I just wanted to follow up what should I call you Dr. Everett? Is that the said? And in the chat, I put it's really important. There's this super, if you don't know about it, it is a really user-friendly app called 5Calls, and you can have it right on your phone. Yeah, Kate's shaking her head. It's it makes it so easy, and you can just scroll up, see the what you want to make a call about. You can do this in 5 minutes, because they make it so easy, because even for bold people, it can be intimidating. What do I say? How do I say it? It gives you the script. It puts you right in touch with the person. You don't have to do any research. It's done for you. It's so user friendly. So I'm sharing this 5Call things out on Facebook. I'm sharing it everywhere. Because like I think Danita said, I think it's now up to 1,900. It was great. Last time I heard it was 1,400. Let's get it up to 3,000 calls a day. And start the squeaky wheel thing. And something else that's coming to me, and I'll be quick, Danita. And I'm the oldest of 5 kids, right? And maybe it's an oldest child thing, but it's also not lost on me that I'm white and I was the oldest child, right? So I was raised to be bold in a particular way, but that can also translate to entitled, right? But there is that bold thing, and this is where I think coming together, and Danita, we might have this as like a topic, that we can talk about sometimes, because when I hear Dr. Everett speaking and Dr. Hubbard McCree speaking, I'm hearing confident women owning their power, right? And sometimes women, for whatever reason, they don't have access to it. But I think as sisters, we can give each other the permission to step into it. And sometimes we might need a script, right? Or encouragement. But I'm hearing this as a way we can support each other and just love the power of the story thread. So anyway, just wanted to put that out there.
Thank you,
There's
Teresa.
been
Thank you.
several affirmations in the chat too, so thank you
Right.
for thinking of that.
Yeah, thank you for putting that in the chat. So my final question, and I think we might have talked about it a little bit already, but can you either of you identify some current policies that impact the health disparities that we've just talked about among women?
Well, I'm going to definitely tell you, for one, if you're not following the now it's Braidwood versus Kennedy lawsuit that's now before the Supreme Court, you really, really want to follow this if you haven't already. And just to make it personal to you before kind of going to the bold allyship of looking for other folks, how many of you in the last 2-3 years have had a wellness visit that cost you $0? How many of you have had a well woman visit at your GYN that cost you $0? That is directly related to the fact that those are recommended services from the United States Preventive Services Task Force that were deemed to be zero cost dollars to the individual who has health insurance because of the Affordable Care Act. Braidwood versus Kennedy would take that away. And so people are not as tuned in, right? Because you hear about legislation on television, you're like, okay, maybe I understand that. I'm not really sure. Folks are talking about that, but we're not talking about the strong litigation strategy that is also happening that puts a lot of healthcare at risk and at danger and will exacerbate health disparities. The Braidwood versus Kennedy lawsuit at the Supreme Court is going to be heard on April 21st. And folks have already put in a lot of their what are called amicus briefs, friends of the court briefs, that explain the importance of this. So at this point, we're in a watch and see mode, other than, as Donna had mentioned before, there will surely be protests. There will surely be people who are sitting at the Supreme Court's front steps when this happens. I'm imploring you to literally watch what happens here, because I think it sets the stage of how far back we're going to go on preventive healthcare services for everyone, and women particularly.
Tekisha, can you put it in the box one more time, if you don't mind, when you're
Oh,
finished?
sure.
That would be, and that way everybody can see it. Thank you.
Sure, absolutely. I think the other policy choices and things that I think we need to be mindful of, particularly when we're talking about women and talking about women at the intersection of race, I think we need to be very mindful of what's happening in the field of maternal health care policy. I think this is really, really important and significant. We haven't said a lot of statistics tonight, but at the top of the call, we talked about some of the disparities. And fun fact, not so fun, but Black women, regardless of socioeconomic status, and I'm going to say that again, Black women, regardless of wealth, education, and or income, are dying from preventable deaths from having babies that are very much unnecessary in the United States. And at risk of that are policy decisions that are shrinking our healthcare access, that are shrinking our healthcare workforce, that are shrinking our ability to look at the data and understand what's happening. All of these things that are happening these are decisions that are being made at a policy level that will impact the future of maternal health outcomes. And I think that's really, really important to not only pay attention to, but to engage in and to talk about really important stories. Now that comes across as who can provide birthing rights, like who can provide birth care. People support midwives. I'm not here to advocate any particular policy position. I'm just saying from the level of thinking about who can provide care in a state at the top of their license, whether midwives are there and are they able to be covered under insurance and provide birth and get reimbursement for providing birth. There are a number of different things on the way around that, thinking about DEI and healthcare and what that looks like. There are a panoply of policy decisions that are going to impact maternal health outcomes, and I implore you to engage on that. And then the last part that I'll bring in to the conversation about policy decisions is to be really to understand and to be vigilant about what's happening to our public health workforce and what's happening in our public health system, because ultimately, here's the connection of what we know. Healthcare is about individual care of individuals and getting them at a collective of individuals, but it's about getting an individual to their best healthy state at any given time. But public health is about population health and moving community and population to a healthy status. And without public health being able to have robust and resilient access to the work that they need to do in community and with community, we're going to see more sick care in our healthcare systems from things that we can prevent from public health interventions.
I totally agree with that, coming from the public health background. I think that you're going to see a lot of the issues being kicked back down to the states. And so things like Medicaid expansion and the Affordable Care Act, I think those issues are going to be, because if you can't pay for your health care at all, if there are issues, then I think that's going to be a problem. But just in terms of the public health piece, no one's talking about the vaccine issues and the advisory committee that actually makes recommendations around those. And that is a group, I remember being at work, and that is a group of well-trained experts. That committee was, their meeting was postponed. Don't know when they're going to be meeting. So that means now when we should be getting ready to make vaccines for the next season, we're not doing that. What's going to happen? And then the guidelines around, again, I'll tell you a story. For years, the parameters that were used to determine kidney function, glomerular filtration rate, had a separate, you needed to do that. They were different for Black people compared to everyone else. You were supposed to add a certain rate for Black people. So what happened with that? That meant that Black people were being diagnosed with kidney disease at a later stage because your numbers looked higher than others. It wasn't until, I think it was last year, was it last year? It may, or 2023, when finally someone decided, oh, you know what? This may have something to do with why we're seeing the disparities in chronic kidney disease, the racial ethnic one. So it's changed now. But that had been in place for decades. And no one really knew about those types of things. What if someone decides, and you've heard this in the news, well, people of certain races have a more robust immune system, so they don't need to be vaccinated in the same schedule as others. You have heard that in the news. What if that happens? That's going to be a problem. Those are the things we need to talk about. Those are the things that are going to hit us close to home. And you're right, if the public health workforce is not there, and I think about the work I did for 40 something years. I was a practicing pharmacist when the first cases of what we now know to be HIV were identified. And I watched people die. I mean, essentially, because there was nothing we could do at that time. We have gone into an era now where we have effective treatment and we know how to prevent it. We don't have a vaccine or a cure, but we know how to prevent it. But everybody's not getting access to that. What if all of that were removed because there are some policies around folk who may experience risk? It's not going to stay in one community. Everyone's going to be affected. And I think those small things that we don't think about those, we may be looking at the bigger picture things, which are good. We need to do that. And Tekisha gave some excellent ones. But we got to be concerned about those things too, the public health things. And I always say when people push back on that, equity means everyone has access to achieve their optimal health status. Everyone. If you look at it in that way, then we all benefit. And that is where we're trying to get us to go. Somehow that the equity has been viewed in a different manner, but it means that everyone, no matter who they are, has the option to achieve their optimal health status. And that's what we need to do. And we need to focus on policies that are going to get us there.
Wow. Well, thank you, ladies, so much. Wow, my head is spinning. There's a lot to learn. There's a lot that we need to stay on top of. Thank you for the, what is it, Braid Boy versus Kennedy alert. I feel like public health has always been something that could be left off the budget. So we always need to be concerned about public health. I can say this because I don't work for a federal government entity. Given the person who is now supposed to be in charge of HHS, who does not believe in vaccinations, it adds another level of concern to so many areas, but definitely public health, because vaccinations are something that, we all have access to, but maybe not. Tekisha, you had a aha moment or something you wanted to add.
Well, the aha moment, and I think I'm safe in saying this. One, I don't work for a federal entity at all, and I don't have any federal dollars. But just to make a connection back to your question about accountability, let us not forget that Senator Bill Cassidy voted in the affirmative for Secretary Kennedy because Secretary Kennedy consistently said he wasn't going to go after vaccines. So when you talk about accountability, go back to the record, right, of what was said in the confirmation hearings, which gives you the ability to hold accountable, though he's not an elected official. Well, Cassidy is, Kennedy is not. But it gives you the ability to hold accountable for what people have said publicly on the record for what they are and are not going to do. So if actions don't follow suit, there's an ability for people to take that record and understand what that means for them if it's something they care about.
Any other questions or comments? Well, thank you, Dr. McCree. Thank you, Dr. Everette. I so appreciate your insights, your experience, and what you've shared. And before we go, I'm going to turn the mic over to Kathy Santora, our President of the Board of Directors of the Maryland Women Heritage Center.
Thank you, Danita, and thank you to all three of you, Danita, to Dr. Everette and Dr. McCree. It's what a unique and wonderful conversation to have in this safe space. I caught on something that Jerese said about women coming together and giving each other permission to, as she put it, step into it. And I think when you're alone in a doctor's office, when you're alone watching the news, it's kind of hard to know where to turn. And it's these gatherings of women giving each other strength that I think is just so empowering to me anyhow. And the only thing I would add to that is, because we're the Maryland Women's Heritage Center, to also take some inspiration from the women who have come before us, the women who have fought for justice, fought for equity, fought for pretty much everything over the years. And that's why we exist. And the combination of today's women and yesterday's women can come together to be a really powerful force. And this has just been a wonderful conversation. If you would like to know more about the Women's Heritage Center, you can go online or contact me or Diana. We do have a really cool upcoming program also on March 8th. So if you can kind of balance those two events on Saturday, March 8th,
We have a photography exhibit in our space at 333 North Charles Street. And the photographer took pictures of 24 creative women over the age of 55, and a lot of them will be there that day. And it's just a wonderful photo exhibit of the power of creative women, and the power of older women, I guess is the best way to put that. So thank you everyone for coming and taking part in this conversation.
Everyone have a good evening, and thank you again for coming in. Thank you again to Donna and to Tekisha.
Yeah.
Thank you so much.
Thank
And,
you.
and if
Thank you
the,
so
if
much
the
for having
panel would
us.
hang on for a second, we'll have a quick debrief. If you can, real quick.
I have to run to another one, but hold on, let me see.
Go ahead, Donna. 'Cause I know you've already said